I know a lot of behavioral analysts don't like talking about, sensory properties of food, but I'm a big believer in it. There's a huge literature in food science of why we eat what we eat, right? Why is it that behavioral analysts don't want to talk about that? Why don't we look at sensory properties of food? Can we match those? And is there a way to is it possible that if we start with those foods first, that then we may get generalization of these other foods later, and then we can keep the refusal behaviors down by doing that versus starting with broccoli?
All right, guys, welcome to another episode of Beyond the Science. We are live here at the FABA conference, 45th anniversary celebration at FABA. That is crazy. It's been a long day. It's been a crazy day, but I feel energized because I thought our day was done, but we had the best for last, right? How you feeling, Wes?
Thank you.
I'm feeling very energized right now.
Yes.
So glad to be here.
Yes.
So glad to be here.
Welcome, Dr. Meeta Patel, founder and executive director of Clinic for Kids. Is that
Yes.
right? Researcher and leading expert on pediatric feeding disorders. Thank you for joining us here today at FABA. Welcome to the show, Wes.
Thank you for having me.
Yeah, so talk to us. How's FABA been for you so far? Have you had any favorite sessions so far since you've been here that you watched?
Yes, actually, FABA has been amazing. I haven't been back since I was a graduate student of Dr. Jim Carr's, and coming back, FABA has changed tremendously, and it is wonderful to see a regional conference at this level. So one of my favorite talks that I went to, there's a couple. One was Dr. Zarconi's talk on research and doing research in applied settings. And it really resonated with me because that's the type of work that I'm trying to figure out what is the best way to do clinical research in the natural setting. And that's the type of work that I do. I work in the home environment with children with feeding problems. So
yeah. What made you want to focus primarily on the home in your work?
I think before I did my postdoctoral fellowship, I worked with children with autism. I wasn't doing feeding work initially. I was doing work, early intervention work with children with autism, but I always found that a lot of children with autism had feeding challenges, and I wasn't really sure how to address them. And when I was a grad student, Dr. Kathleen Piazza came to do a presentation. And when I saw her speak, I said, I want to be that woman one day. How can I learn this? So that's when I decided to go do a postdoctoral fellowship at the Kennedy Krieger Institute with her. And that's how, then it was history.
Wow.
Then I didn't go back. So.
Wow. Shout out to Dr. Piazza. She's just
Incredible.
amazing. She's amazing. Now, so your specialty is pediatric feeding disorders. For people who don't know, what does that look like on a day-to-day in the home when you're working with feeding? Can you just kind of give our listeners who may not have insight, what does that entail on a day-to-day basis?
Yeah, so the children that I primarily work with, I work with a variety of feeding problems, and children some of them could be typically developing, some may have other developmental disabilities, some may be on the autism spectrum. So the actual diagnosis can vary, but the types of feeding problems I work with, it ranges from working with children who are tube dependent all the way to children who are extremely food selective by type or texture, or have oral motor deficits, and we're working on advancing their texture. So we in our program work on all of the feeding problems, and like I said, everything is done in the home environment.
Yeah, this is nice. This is nice. Wes?
So in regards to the process, right? So when you're getting started with the client and stuff like that, how important is the parent involvement in the success of being able to, reach those goals?
It's without the parents, we couldn't do what we're doing, and we wouldn't have the outcomes that we do have. Our outcome measure paper was published in 2022, and without the parents, there's no way to get that type of outcome. And our program is a monthly program, so we see the patient intensively all day from breakfast to dinner for those days that were there, initially 5 days and 3 days a month. But the family has to follow the treatment plan in our absence. So if they're not following it when we come back for the next visit, then we can't advance. So the whole goal of our program is at every visit we're advancing, their feeding skills, basically.
Yeah, that's a really good Because in the home, so like I know, like we had, the clinic intervention and stuff like that, I would assume that the parents' role is important in general, but really in the home especially too, because you're relying on them in your absence to continue to do the interventions that you guys are working on. And I know you recently did a presentation here at FABA. Can you kind of quickly talk about your presentation and what was the one main takeaway that you hope people took from your presentation?
That's a great question. Going back to one last thing I want to say about the parents is that they definitely are the behavior change agents, and sometimes when you're doing this type of work in more controlled environments, it's more challenging because the parents are not involved from the get-go. So what happens is therapists are able to work with the child. They're able to, reduce their inappropriate behaviors before sometimes the parents get in. We don't have that luxury. Sometimes we are having the family implement as we're trying to evaluate what is the best treatment. So it gets a little challenging. So that's what my presentation was about. I did an overview of how our program works, but the main take home point, there's a couple. One is that we need to continue to do, even though we're working in a home environment, we need to use scientist practitioner model when working with children with feeding problems. So we need to use the existing literature, and that's what we do in our program to build our assessments and treatments, but also to develop new ways of treating these problems in less structured environments. So my take home was, typically in our program, we don't do traditional functional analyses. We feel that we have enough information we know now that in part, these inappropriate behaviors are maintained by negative reinforcement in the form of escape. So my whole program now is built on what antecedent variables do we need to manipulate and how do we come up with a starting point for treatment. If we have the right starting point for treatment, then we may be able to keep emotional responding down and potentially keep some of the inappropriate behaviors down. So we're doing a lot of research in our program, figuring out, does it matter to start with specific foods when we start treatment, like specific bite size? I mean, there's a variety of different antecedent conditions that we need to evaluate to determine what the starting point is. So I think for me, I want us to keep talking about starting points. And for children with autism, I mean, I had so many people after the talk come talk to me, and they work in ABA companies, and they're faced with having to work with children with feeding problems where they don't have the expertise to do that. And so they're asking me, what should I do? And my first advice is, if you don't feel comfortable, which you shouldn't, you should not be, treating problems that are out of your scope, right? And so I said, you need further training, or your company needs to reach out to other people who are experts, because that is the very problem that we're facing is, and it's really not the BCBA's fault either. They are asked to treat these problems that they don't have training for.
That was going to be one of my kind of next follow-up questions. So getting into that type of work, right? When we talk about being able to address eating disorders, stuff like that, there is that interdisciplinary sort of collaboration that you have to bring into the port, right?
Exactly.
Or are there any providers that you've had to start working with that really helped to benefit and kind of bring to the table to help excel the work that you were doing? Or were there some that you had a hard time to try to communicate, like, hey, this is what I do, how I do it? How did that sort of gap get bridged?
I love that question. I think this interdisciplinary, multidisciplinary approach is the key. And we, as behavior analysts, need to understand, how do we work amongst other people and take their expertise and how do they use ours and we use theirs, or we work together. And I think that's the problem. And especially with feeding problems, I don't think behavior analysts alone can treat these problems. There are underlying medical issues, there are oral motor issues, there are nutritional deficits, other psychological issues. I mean, there's a lot going on. And in our program, that's one one part of my program I do want to build is having a physician or a nurse on staff, which we don't currently have. But we do have a dietitian on staff, and we do have our own speech and language pathologist. So we're able to collaborate and come up with assessment and treatments as a team. But the medical piece, we don't have that currently, but we work with the child's existing medical team. And I'm also a faculty at Stanford University, where we receive a lot of referrals from Stanford. I'm actually in the pediatric gastroenterology department. Nice. So that helps because I actually have, contacts that could help us when we're, faced with some other medical issues that are going on.
Yeah. Wow. God, you're listening to Beyond the Science. We're live here at the FABA conference. Meeta Patel is gracing us with some time here.
Please, thank you.
Now, you've been on the JAVA board, and I have a question with regard to the literature and the research. How do you see the literature and the research evolving over the next 10 to 15 years, specifically when it comes to feeding?
Well, I love that question about research, and I'm finding once I left the Kennedy Krieger Institute and the Marcus Institute, if you look at my publication record, it went way down. And it went way down because of the environment that I'm working in. And so I was fortunately able to bring on a doctoral level person a couple of years ago, Dr. Anderson Weber. And because I have a little bit more support, we're able to get some of this, some of these studies that I conducted literally 10 years ago. Wow. I was thinking about these things 10 years ago, but we're finally getting them published now. And so I was thinking about these things years and years ago because I had to change the way I do research. I couldn't do it the way I did it when I was in an inpatient or a day treatment program, right? Research is just done differently. We don't have as much control. Sometimes we have to make changes that then we don't have experimental control. So it's been very challenging for me to publish, to be honest. And I feel like the criteria are the same. But I am going to give a shout out to Dr. Ibanez because she really helped me with a paper that I didn't think would get published, but she saw value in it because no one else was doing it. And so I hope that if you're working in the environment that I'm at, that they don't have the same standards of rigidity that is required for research. I think that, demonstrating experimental control is so important, but there has to be outlets for people like me to publish their work because even practice journals, they're similar people that are on these review boards, right? So it doesn't matter. I'm getting the same reviews. So that's been very challenging and very punishing for someone who who's using a scientist practitioner model, but is unable to get their stuff published as easily as we should. So hopefully we'll have other outlets and hopefully things will change, and the value in doing this type of clinical research in applied settings. Yeah,
because we need that data. I mean, the work's being done. I mean, consumers are thirsty. I would say for MO is high because it's happening everywhere. People want to know. People have the need to want to know how do I treat? We need professionals like you to be putting things out there. But when there's barriers in place, that makes it a little bit harder. So I'm hoping that we can help push this along. And I hope this video even helps too, pushing this along. Yes.
What is one myth that you would like to address or bust about eating disorders with?
Oh, I love this question. The problem that I think we're facing is there's different people doing different feeding work. And there's groups of people that are saying that we shouldn't be using escape extinction, for example, right?
Yes.
And
large group of people, by the way, saying that.
Exactly. So the type of patients that I work with are very medically complicated, and in some cases, escape extinction is unavoidable. But the type of research that I'm doing now, and that's why I'm saying starting point. If we have the right starting point, even if we have to use escape extinction, potentially we could keep those inappropriate behaviors down and emotional responding down. So I think when people think escape extinction is force feeding and the child needs to have all autonomy, I actually am not in favor for that. I am in favor for really understanding antecedent conditions and evaluating the right starting point for patients. But why is eating, I mean, a child doesn't have they don't have the choice necessarily to go to school, do their homework, or even medical procedures, right? Like tube feedings, right? Isn't that force feeding too?
Yeah.
But they would die if they didn't have the tube feeding. So we have to look at those factors, right? Is certain things, I do believe in choices, I do believe in autonomy, but there has to be a balance of control.
Yeah.
And so whoever thinks escape extinction is wrong and bad, I'm here to tell you it's not. I work in the homes, we do this, we train caregivers to do it, but we do it in a way where we're keeping the emotional responding down.
Wow. You better get some people in our DM on that one, because I already know. But when Mira was on, shout out to Mira, she made a point, there's situations where a client may be malnourished. And that's like the only way we can get nutrients and things in them is to use those escape extinction procedures. And when she put it like that, I was like, man, yeah, at that point, it's almost life or death.
It is life or death. If they didn't have a tube, it is life or death.
Yeah.
And some of my patients, some of them, they can't actually get a tube because they have other medical issues. So we have to get them to, I don't know, if they've had a liver transplant and the family is not really comfortable with getting a G tube, then we have to get them to eat orally. Yeah. Right? And this is what I said at my talk too, is I think when I first started in the field, I was doing whatever at all costs. This kid has to eat. I'm thinking about this differently now. We have evolved. All of us are doing things differently. It's not just me. All these programs have evolved. And one other thing is, I don't think every patient is appropriate for my program either. I think some need to go to day treatment or intensive inpatient programs. If they are so medically complicated, they need medical supervision. We don't have that currently. And that's what I would recommend.
You just took my question right out of my mouth. I was literally getting ready to ask that, but I'm going to still ask it. Have you ever been in a situation where you felt like, they needed to be referred out to someone else? And so in that moment, what were some of the key indicators or criteria to where you were able to recognize, okay, I might not be the best fit? And then if you weren't, where would you refer them to?
I mean, of course, I'm biased, and, a lot of my referrals would be based on, my colleagues at the Kennedy Krieger Institute, the Marcus Institute, and obviously now Dr. Ibanez with her feeding program. So these are people that I trust, and we have similar philosophies, even though our environments are different, that we work in. But if I see that obviously if I'm looking at the data, right? And I can see that usually within a month when we come back within a month, if we haven't seen a lot of progress, and we don't after 3 months, and other medical issues arise, then I'm going to refer them out to a more intensive program. But by the time they come to me, they have exhausted all local programs. So, I think the parents are more motivated to actually implement the treatment protocol. So I have that going for me also, that's one of the factors. Like if the family is just unable to implement this treatment protocol with high integrity, and we're just not seeing progress because we're only there physically once a month, right? Yeah. So that's when I would have to refer out as well, even if there wasn't any medical need, but we're not there. We're not there for 8 weeks straight. Yeah. Right. So I am fortunate that I have very motivated parents, because we're the last resort for families in the San Francisco Bay Area. And I have a clinic where Holly Nay is helping me in the LA area too. Wow. So we're kind of in 2 areas right now.
Oh, you're in LA, huh?
Yeah, okay. Yeah. He's on the West Coast.
I'm in San Diego.
Oh, really? Yeah. Oh, that's where we see patients.
In San Diego,
in San Diego too. So it's more southern LA.
What part? What area? What city?
It's Orange County. Mostly is Orange County.
Gotcha.
I gotta connect you with some people I know out there.
That's not too far from me.
Yeah. Cool. No, this is good. I mean, I feel like we could talk about this for a whole nother hour. I have a couple of questions. I'm gonna let you go. I know we told you 20 minutes. I know you've done some research on decreasing the tube and more increasing the oral intake. Have you seen any breakthroughs recently with regard to those, particularly when it comes to those things in terms of the decrease in the tube dependency and increase in oral?
I honestly feel like most people in our field are pretty good at how to reduce the tube and get intake going. Here's a caveat with using lower textured foods because it's less response
yes.
effort. We can get them off of the tube with purees and a high calorie drink.
Yep.
But what we're doing in our program more recently is we see developmentally where our patients are, and we might not be doing purees for long. Like I had a patient, I presented some data today on her, and she Holly saw her last month, and we did start with purees, but this was the second month. We were able to increase variety, like the bolus. The family was doing great in the month. So this month we already started working on texture. And so we're like, developmentally for a 19-month-old, it makes sense to start working on texture early. We don't need to get her off the tube with purees. We could do some combination, but we needed to get some acceptance going with something that was low effort that she had the skills to do.
Mm-hmm.
So I hope that that's where our field goes a little bit too, is not get stuck in this pigeonhole of let's just keep doing purees. I think we really need to look at developmentally, where do we need to go?
Yeah.
And then I know a lot of behavioral analysts don't like talking about, sensory properties of food, but I'm a big believer in it. There's a huge literature in food science of why we eat what we eat, right? Why is it that behavioral analysts don't want to talk about that? Mm. Why don't we look at sensory properties of food? Can we match those? And is there a way to, is it possible that if we start with those foods first, that then we may get generalization of these other foods later, and then we can keep the refusal behaviors down by doing that versus starting with broccoli?
Wow.
Meeta's coming in hot, y'all. She is coming in hot. Woo, I'm about to get people that DM on this one.
I got one more question. Okay. One more question. This will be my last question.
Okay.
I promise.
I love this.
How important is gut health into treating the disorder or necessarily getting started? Is that something that is, I'm assuming, right, when you're talking with the other practitioners and doing that kind of collaboration, right, that's talked about and mentioned. Is that something that's, if we were timelining it, something that's right in the beginning we're talking about, or is it just like, where does that fall into this type of?
Love that question too. That gut health is critical, and you need to address that before we start treatment. But the problem is sometimes there aren't great tests, right? And the tests show nothing, but the child is still throwing up 10 times a day. So do we not start treatment? No, we do start treatment, but we figure out other things. Is there something about the schedule that's causing the child to vomit? It may not be reflux. I have patients that have volume sensitivity, and the GI doctor may not be completely aware that maybe we should change this schedule. So I work very closely with GI doctors to say, look, we need these total number of calories, but once you get over that hump, that's when we're seeing the vomiting. We show them the data. So then we back down on the volume, because if you're going to give that volume and throw up, you're not going to gain weight anyway. Yeah. Might as well get less and decrease the negativity with eating, and then work our way back up. So there's a lot involved that I feel like behavior analysts do an amazing job looking at data, collecting data, showing that to physicians. I mean, my physician colleagues are like amazed at the work that we do. And they're amazed that I can't get some of this stuff published. I think that's where, our field probably needs to go. But in medicine, if you look at some of their studies, there's not a lot of detail. They want to, some of these case studies, they want to see that this worked. Yeah. What did you do? I still believe you need to understand why it works.
Of course, of course.
But I think gut health is critical, and you need to keep evaluating it before and during treatment, because things can change, and really understanding if there's food allergies and staying away from them, because we don't want to create more negativity with eating. We're really trying to break that connection, and we're trying to create eating as being, again, behavioral analysts might not love this word, enjoyable. And like I said in my presentation, it might not be quantifiable enjoyment, but that's what we need to create. We need to figure out what our assessments and treatments are now, so enjoyment happens. And that is really, this next half of my career is going to be devoted to that.
because you know why? We wouldn't need a treatment program. We wouldn't need a treatment.
Yeah.
We wouldn't need people to implement them if we actually figured out how to treat them so they actually like eating.
Yeah.
That's
Oof.
true.
You know?
Meeta, you better talk your talk, girl. Man, you better talk.
I don't know if I'm going to make any changes, but I hope so.
Yeah,
I hope I can.
This is amazing because there's a whole different school of thought out there from what you're saying. I love the healthy disagreements and your point of view and kind of where you're coming from. So no, this is great. We're gonna get a lot of questions on when we post this, and I'm here for it. Let's go beyond the science for a little bit here before I get you out of here. What's one thing about Meeta that maybe just peek behind the curtain that people don't know? Maybe that's how your presentation. Let's give us one fun fact about you.
Oh, fun fact. I'm a shopaholic. I love shopping. I love fashion. I actually wanted to be a fashion designer before I, got into behavior analysis. I actually got into behavior analysis when I was in college. I started working with children with autism my sophomore year in college. And prior to that, I really thought I would want to do something in fashion.
Wow.
So
we could tell. Awesome. I'm here. I window shop. But,
I phone shop. I have sleep problems too, so I just phone shop.
That's about all I do. That's about all I do.
News.
This has been, amazing. We thought we were done. Viv, shout out to you. I can't see Viv. She's in the crowd now for bringing me on. You were just brilliant.
you.
Breath of fresh air. Just so
Yes.
much. I feel the passion. When you say you're going to spend the second half of your career, I feel it. Like I feel like I follow up with you in a couple of years and you're going to do some damage. So thank you for your advocacy. Thank you for your work, your research, for presenting here. Like we really appreciate the work that you're doing in our field. So for people who want to learn more about your work, where can they find you?
They can find me at Meeta, MEETA _Patel, PATEL, at Clinic for Kids, CLINIC, 4, kidskidz.com.
We'll put it right here and we'll put it in the link. Thank you so much for
Thank
spending some
you for
time with us.
having
I know you
me.
presented
This was
today.
great.
This was
Oh,
awesome.
this was fun. I wish I could do this all the time and people actually listen to me.
Guys, thanks for joining us.
Yes.
We're wrapping up here today at FABA. Shout out to everybody who presented, everybody who came on the show today, to FABA for having us on here. Shout out to Alex G Productions behind the microphone. He's been working all day today. We'll see you guys tomorrow, and everybody have a good evening. Thank you.
Thank you.